Hello doctors, my name is Dr. Saif and I'm a critical care specialist. Acute ischemic stroke accounts for approximately 70 to 85% of all strokes worldwide. It is very common to see hypertensive response in the first hours and days after acute ischemic stroke onset. Patients' blood pressure will be very high when they present to emergency department. This hypertensive response is something which bothers us because it strongly influences clinical decisions and increases the risk of acute complications. Therefore, we need to control high BP to prevent further damage to brain. However, this response is beneficial also to maintain the cerebral perfusion pressure in areas around the dead tissue, which is known as penumbra. However, there is a limit of this tolerable blood pressure. Main goal is to maintain the BP within a safe range to prevent complications such as hemorrhagic transformation or recurrent stroke. In the acute phase of AIS, this transient reaction is termed as acute hypertensive response or AHR, which is observed in about 75% of stroke patients. So it is quite common. Now we will know what are the factors which can lead to AHR. We should know because sometimes response is exaggerated due to presence of these factors, and if we could prevent these factors or we pay attention to them, the dose of antihypertensive therapy which we use will be lower to control the blood pressure. So there are set of pre-existing conditions which can lead to AHR, such as inadequately treated or undiagnosed hypertension, which can mimic as AHR. Patient was not compliant to treatment on OPD basis, or he was not consulting a doctor at all, or never knew that he had blood pressure issue. So he is coming with the hypertension and stroke both. Most of the time, acute hypertensive response is a consequence of stroke related factors. What are these stroke related factors resulting in AHR? Let's know. See, ischemic damage to the brain region involved in autonomic regulation can cause AHR. So dysautonomia is one of the causes. Similarly, activation of adrenomedullary pathway or central sympathetic pathway or outflow can also result in AHR. So these two are central causes. More commonly, easily preventable factors which can result in AHR, such as urine retention, cerebral edema, headache, all can lead to AHR. Sometimes stress and anxiety related to hospitalization and fear of complications of stroke can itself result in AHR. So you know there are multiple factors which are possible which can lead to AHR, and you can control them. So next time when you see a patient with acutely high BP, try to recognize these factors. Now we will come to control part, which is more interesting and for which you are waiting. So should we control the blood pressure? If yes, what is the target? What are the drugs available? So these questions should be born in your mind. Now, in the pre-hospital phase, while patient is at home or during transit in ambulance, do not try to control blood pressure even if it is high. There was an interesting trial done on this aspect. The name of trial was Right 2 trial. So in this trial, in this multi-center prospective RCT, paramedics applied a transdermal patch of glycerin trinitrate to a group of patients with presumed stroke within 4 hours of onset and having systolic blood pressure more than 120. Between 2015 to 2018, about 500 paramedics from 8 UK ambulance services recruited about 1149 participants who received intervention. Okay, the primary outcome was modified Rankin scale at 90 days. Those who do not know what the Rankin scale is, Rankin scale is a tool used to assess the level of disability or dependence in individuals who have suffered a stroke or other neurological condition. This score ranges from 0, that is no symptoms at all, to 6 is death. So as score becomes higher, indicating the more disability. So what was the results of this trial? Now we should come back to the result part. The result of this trial was negative. There was no difference in the modified Rankin scale at 90 days. Median score was 3 in both groups. So this is the reason we should not control the blood pressure. However, once patient reaches to ED, in hospital settings, there is a benefit of lowering BP. but not in all cases. Only in cases where you are planning for thrombolysis or thrombectomy, you need to lower the BP to less than 185 over 110 millimeter of mercury. Otherwise, both American Heart Association (AHA) and European Stroke Organization is ESO guidelines indicate that patients who are not qualified to receive either thrombolysis or thrombectomy, we should not control the BP until unless it exceeds 220 over 120 millimeter of mercury. So that is your cutoff. Problem with the severe hypertension is that if you are planning for thrombolysis and thrombectomy and there is a severe hypertension, that can lead to some issues like recurrent stroke or hemorrhagic transformation, which has been seen in a retrospective analysis. So the risk in this retrospective study increased linearly, being 4 times higher in patients with SBP more than 170 millimeter of mercury compared to those where the BP was targeted between 140 to 150 millimeter of mercury. So 140 to 150 was the target systolic blood pressure in this retrospective study. Recently, a RCT was conducted, which was known as Enchanted trial, which was conducted in patients who received thrombectomy. They found that the risk of hemorrhagic transformation was very low if the systolic blood pressure was achieved between 130 to 140 millimeter of mercury. So there was a positive benefit of controlling the blood pressure. But this trial did not show any benefit in the clinical outcomes like death or disability. So by now you know why to control blood pressure, what is the target. Now you should know how to control the blood pressure, because doctors are confused about various agents to be used, how to use, what monitoring to be done. So these are important questions. Okay. So first you need to use intravenous medications such as labetalol, nicardipine or nitroprusside or enalaprilate. So all are short acting drugs. So that can be administered and you can achieve the blood pressure control effectively and very fast. We use labetalol infusion with injection hydrolyzin boluses. In such cases, monitoring is a must. I will advise IABP monitoring, that is intra-arterial blood pressure monitoring, but the people are not very comfortable with the arterial line placement due to rare complications, or they do not want to put simply because of lack of time. See, IABP will guide you to achieve target blood pressure confidently and you can titrate the drug infusions accordingly. So, if possible, IABP is must. You can switch infusion drug to oral medications gradually after 24 hours for long-term control of blood pressure. So that's all for today regarding the BP control in stroke patients. Thank you for your attention. See you in next video.